The other layer of inequality or iniquity is rich and poor. For me, I've had myself, my wife, and my children vaccinated, whereas there's somebody in my country who is high risk but lives in a rural county where health access is poor and has not had vaccination. I must also feel responsible for that iniquity as well. And I must also call it out and see how that can be overcome so that this is not one-dimensional. We call iniquity across. And finally, it's also urban to rural. And I wanted to show you the inequity. The global inequity is very clear on the upper graph here. And you can see it's like Africa has never had that there are actually COVID vaccines. It is still white, meaning very few people, between 0 to 20 per 100 by December 6th, who have actually been vaccinated. Whereas most of Europe, North America, and Asia are on the upper side of vaccination. So that kind of tells you, we don't have to go into depth. I think Maza already talked about the numbers. The one I wanted to also show you is this in-country inequity. And the thing that we must call out very strongly is that the challenges we are having with vaccine uptake in sub-Saharan Africa, in low-income countries, is not about hesitancy. It is mapped very clearly. And again, I would challenge Catherine to work with me to do some more data here because she's actually the researcher. I'm not. I just kind of look at data and try to understand it. To say that actually the uptake of vaccines is inversely proportional to access to health services, or directly proportional to access to health services, sorry. Is directly proportional to access to health services. And if you look at this chart from Kenya, what I've done is overlaid some data on vaccine uptake onto a chart that was existing on a mean travel time for an individual from where they live to a facility that actually carries out vaccination, not COVID vaccination, general vaccination, meaning that if you want DPT for your child, what is the mean travel time for you? If you want measles for your child, what's the mean travel time for you? And you can see, if you ignore the red and the green line, and you just follow the other data at the bottom, you will see that these counties, Kenya has 47 counties, these counties on this end, on the far end, have a mean travel time to a vaccinating facility of almost 3 hours, more than 2 hours, mean travel time. Whereas if you look at the beginning of the curve, where you look at Nairobi, which is the capital city, they have a mean travel time of 20 minutes. And then if you now look at, you overlay vaccine uptake, you will see that where there is actually a mean travel time of less than 20 minutes, the vaccine uptake in Nairobi is 40% for 2 doses. But where you have a mean travel time of more than 2 hours, vaccine uptake is less than 2%. So it is a health access issue. And this, if you mapped here access family planning, you'll find exactly the same pattern as vaccine uptake. If you mapped here DPT, you'll find the same. And this is where you're more likely to find 0-dose children in this end where travel time is very high. So this must also be called out. And we must use this data to show that actually the challenge we are having is not hesitancy. It is access to supply and then access to vaccination. And that access to vaccination is the same as absence of UHC. Because where there is low universal health coverage, low access to essential health services, because of distance of facilities, lack of health workers, lack of financial protection, is also where we have low vaccine uptake. It is vaccine access. That's the problem. That's why we are running this petition, which Desta will call up, talk about a little later. But please sign this petition. We already have 36,000 signatures. So people support the end to vaccine injustice.